for your time.
Thank you very much for your time.
Appreciate it. Okay. Oh, here's someone I've been looking forward to seeing. Hearing from the Pulmonary Hypertension Association of Canada, Angie Knott. Come on up and tell us all about what you've got to say. Welcome. Angie, you got 10 minutes for the presentation. I'll try to give you a high sign when you have a couple minutes left, and then we'll go to questions. Thank you. The floor is yours.
Thank you very much. So this is a brief presented by the Pulmonary Hypertension Association of Canada on behalf of the patients and families affected by pulmonary hypertension in British Columbia. The Pulmonary Hypertension Association of Canada is a federally registered charity. Our mission is to empower the Canadian pulmonary hypertension community through awareness, advocacy, education, research, and patient support. We've been working to better the lives of Canadians affected by pulmonary hypertension since 2008, and we represent the Canadian pulmonary hypertension community, which consists approximately of 5,000 patients, and roughly 600 of those reside in British Columbia. We provide direct support to our BC members through both national programs and through specific programs delivered both in the Lower Mainland and on Vancouver Island. And we collaborate on a regular basis with the BC Pulmonary Hypertension Society to serve the province's pulmonary hypertension community. So, because I suspect none of you have ever heard of pulmonary hypertension before, it is a rare but very complex and serious lung disease which is progressive and fatal. It's defined by high blood pressure in the lungs, which leads to the enlargement and weakness of the right side of the heart, and a serious type of heart failure, and it can strike anyone, regardless of age, sex, social, or ethnic background, though it does tend to prefer women in the prime of their life. PH is difficult to diagnose because it shares many of its symptoms with other conditions. Because of this, many people are misdiagnosed. Without treatment, the average life expectancy of somebody living with pulmonary hypertension is less than 3 years. And ironically, many patients spend 2 to 3 years of their life seeking an accurate diagnosis. It's estimated that approximately 500,000 Canadians have been diagnosed with this disease, but as many as 10,000 may be affected by the condition. There is no cure for this disease currently, but there are 9 pH-specific treatment options that have been approved by Health Canada since 1997. And thanks to these advancements, many PH patients are living longer and healthier lives. With respect to British Columbia specifically, it's really impossible to know the exact number of people who suffer with PH in British Columbia. This is something that rare diseases often struggle with because we have no registries. However, given that the province ranks 3rd in the population in Canada, we can suppose that the community of PH patients in BC is one of the largest in the country at approximately 600 patients. There is only one clinic specializing in the treatment of this disease in BC, and it is located at the Vancouver General Hospital Lung Centre. Patients who reside outside the Lower Mainland have to travel to Vancouver to receive treatment and be followed by a specialist. Traveling from out of town to receive specialized treatments may obviously put financial strain on patients who are often unable to work as a result of the illness. This situation poses particular hardship to patients living in rural areas who often cannot afford to travel to see their PH treating specialist. Like other rare disease community, the PH community in BC faces many challenges along with the physical burdens and social impacts associated with living with a chronic and progressive illness. These include limited awareness of the illness, diagnosis delays, and uncertain access to the best treatments. So in 2013, PHA Canada commissioned a survey to measure the physical, social, and economic impacts of pulmonary hypertension on patients and caregivers. And that survey revealed that even with the current available treatment, PH takes a significant physical toll on the vast majority of patients and caregivers, and it really limits their abilities to work and perform everyday activities. So I won't rattle off all of the statistics, those are included in your packages, but about 85% of patients experience some symptoms or limitations with everyday activities, and these include things from climbing a flight of stairs or having difficulty walking a short distance. Some even find it difficult to have a phone conversation because of the breathlessness they experience. And the caregivers we surveyed spend nearly 50% of their time on activities relating to caring for their relative with PH. And major issue that these patients face is also a social isolation due to a lack of understanding of the disease. Our survey results also indicated that living with PH makes it very difficult for patients and their caregivers, many of whom are in their prime earning years, to maintain their employment and financial independence. Nearly 60% of those we surveyed reported no longer working or having partially stopped working, and nearly 40% of the surveyed caregivers were forced to make changes to their employment to provide for the care of someone living with this disease. So as an organization serving the community, one of our priorities is obviously shortening delays between the appearance of symptoms and a proper diagnosis of the illness. This allows early treatment slows the progression of the disease, and therefore often patients are actually able to remain in the workforce and they feel better for longer. So we're working with medical professionals all over the country to raise knowledge of the illness within the medical community and to increase public awareness of the symptoms. And as I mentioned, it's a difficult disease to diagnose because it shares so many of the symptoms with other more common conditions. So a misdiagnosis of asthma or COPD, even sometimes anxiety, is really common with these patients. So according to our recent survey, in many patients, the time from first symptoms to diagnosis was 2 years or longer, and 51% of the patients we surveyed stated that their family doctor did not initially recognize the symptoms of the disease and thus did not refer them to the proper specialist. So access to treatment is a big concern for us recently, and it's a concern for patients in BC. As I mentioned, since 1997, 9 specific treatments have been approved in Canada, and thanks to these treatments, patients are living longer and healthier lives. So as I said, untreated 2 to 3 years. On average, we're seeing about 7 to 9 years of life on treatment, and many are living longer than that. However, despite these available treatments, rates of hospitalization have increased by 44% during the past decade. Effectively, 1/3 of patients surveyed through our burden of illness research reported feeling that there are insufficient medication options to optimally manage their disease. Thankfully, there are new and innovative therapies available in Canada, and there are many under investigation as well. So we are particularly concerned about the accessibility of optimal treatment options for PH patients in BC who suffer from 2 particular types of pulmonary hypertension, one called pulmonary arterial hypertension, or PAH, and the other called chronic thromboembolic pulmonary hypertension, or CTEPH. And with respect to PAH, the Canadian Agency for Drugs and Technologies in Health, CADTH, recently released something called the Therapeutic Review Recommendation Report of Drugs for PAH. And the final recommendations of this report seek to severely restrict physicians' ability at diagnosis to exercise their individual clinical judgment essential to the best treatment of pulmonary arterial hypertension. And PAH is a rare type of pulmonary hypertension, affects approximately 15 in every million Canadians. The report specifically recommends an initial trial with one class of PH drugs called phosphodiesterase type 5 inhibitors, or PDE5s, for newly diagnosed patients, which are assessed in functional class 2 or 3. And although this therapy as a frontline approach may be effective for some PAH patient, as a standard first-line approach, it cannot be recommended or justified for the appropriate care of PAH patients. Just like any disease, individual management of these patients, especially because the disease is rapidly progressive, is crucial. So we're concerned that the CADTH recommendations for a stepped approach to initial therapy can be applied to restrict access to treatment for adult PAH patients. If heeded by public drug programs, these recommendations will prevent PAH experts from making prescribing decisions from among all Health Canada approved therapies for each individual patient that will ensure best outcomes for these patients. This restrictive alignment by CADTH is not acceptable to our community, and moreover, Canadian PAH treating physicians, including those that care for patients in BC, are concerned that such uniform and rigid treatment recommendations are not appropriate to look after such seriously ill patients and may actually endanger their lives. The other issue that we're facing, particularly in BC, and BC only at the moment, is unequal access to CTEPH medication. So chronic thromboembolic pulmonary hypertension is another serious type of PH. It results from multiple or recurrent blood clots in the lungs, known as pulmonary embolism. The clots and recurring scar tissue limit the flow of blood in the arteries in the lungs, and it's uncommon, but is usually progressive and life-threatening with a poor prognosis, both in terms of quality of life and life expectancy. If left untreated, CTEPH patients have an average survival of only 5 years, and is the only form of pulmonary hypertension which can potentially be cured through a complex surgical procedure. However, many patients are not surgical candidates or continue to have residual CTEPH post-surgery. So until recently, there were no treatments at all approved for this particular type of pulmonary hypertension. Adempas is the first and only Health Canada approved treatment specifically for CTEPH. It has proven efficacy in increasing exercise capacity, improving functional class, and improving quality of life in these patients. It represents a much-needed medical treatment option for these patients. It was approved in 2013 following a priority review by Health Canada because it is the first drug indicated to treat inoperable or persistent and recurrent CTEPH after surgery. BC Pharmacare decided not to list Adempas for CTEPH treatment on the public drug formulary, restricting patient access to this drug, which most patients will not be able to afford without public funding.
I'm desperately trying to get your attention to give you the 2 minutes, but we're out of 10. You can keep going, but it just cuts into questions.
No, sure. Can I give you my quick recommendation? So all of the other, almost up until now, 8 jurisdictions in Canada have approved this drug, and most of the other ones are expected to do so. So BC will likely be the only one that has not done it. So we have 3 recommendations for the committee. One, really broadly, PH is one of over 7,000 diagnosed rare diseases in Canada. So rare diseases actually affect 1 in 12 Canadians, which makes it seem, a lot larger than one particular disease, which only has, 600 patients in Canada. So in order to facilitate the diagnosis of PH and other rare diseases and to reduce the delay of effective treatment and increase life expectancy and quality of these patients, we urge you to set in place measures to facilitate public awareness of rare diseases in BC. And we would suggest that to happen through increase of resources allocated for promoting rare disease awareness in the province. The province needs to develop comprehensive programs that will aim to better educate both the general public and the medical community on the realities of living with a rare disease and the physical, emotional, social, and financial strains that rare diseases represent for both patients and caregivers, and the importance of not minimizing symptoms and seeking timely medical consultation. We also encourage the province of British Columbia to disregard the flawed CADTH recommendations, which limit access to PAH treatment and allow for physicians to make those very important life-saving decisions for the long-term benefits of their patients. And finally, we strongly urge BC Pharmacare to reconsider their decision not to list Adempas on the CTEPH formulary. We call upon Pharmacare to trust the work being done by physicians specialized in this disease with extensive expertise in the treatment of CTEPH to determine when Adempas is the right choice for their patients. All patients should have immediate publicly funded access to any and all Health Canada approved medications. Thank you.
Okay. Thank you, Ms. Knott. We have a couple minutes left for questions. I have Mike and John.
Thanks, Chair. Great presentation, and having served a 3-year term on the Drug Benefit Council, reviewing all of the horrendous diseases that we have across Canada and British Columbia, and all the new drugs that we have, my impression is that we have a very rigorous drug review program in Canada and British Columbia. You've obviously advocated before the Drug Benefit Council for approval of this drug and weren't successful. It's something that this committee can't do is interfere with the drug review process here, but I'm curious as to what the reasons were for not covering this.
Funding.
Okay.
Thank you. John, please.
Thank you. You mentioned in your presentation you have 600 patients in BC.
Approximately, yes.
Approximately, yeah. But you also mentioned that there was another number you said that you didn't have, but just based on BC being third in Canada.
Yeah, I mean, the statistics are definitely hard to come by. We use numbers of basically me calling the 15 specialized centers in Canada saying how many patients on treatment roughly do you have.
So 600 are those that have been diagnosed already.
And are being treated at the center, yeah.
So, but we don't know how many could have it and
Absolutely,
are just
and who are
not symptomatic yet.
Well, or downplaying their symptoms. So I think we all have a tendency to do this when we experience certain things. We also downplay on our own that we should probably go see a doctor. So
would the medical and healthcare community not sort of be aware that that is an issue for this particular disease?
Because it's so rare, and doctors are often, taught to look for more common diseases. It shares symptoms with so many common diseases. It's often a diagnosis of exclusion, and so that diagnosis of exclusion takes a long time, and so one of the things we're doing as an association is really focusing on educating medical professionals to consider this disease a little bit earlier in their diagnostic process, but certainly a challenging disease just because of the way it comes on, right? Shortness of breath, feeling a little tired. Often people think, oh, you know, I've put on a couple of pounds, I should probably exercise a little bit more. And
I'll stop you. I'm going to go to Spencer because we're out of time.
Absolutely.
Just to say thank you for your work for people suffering and struggling with PH. A friend was misdiagnosed for years, and she let me know about it. And I'm like, whoa, never heard of this before. So thank you for speaking out for those who are a very small number,
Absolutely.
but who certainly need the care and attention. Thank you.
Thank you.
Appreciate that. Thank you very much
Thank
for your
you.
time, Ms. Knott.
I appreciate
taking the time to present to the committee. That's great. That's very informative.
Thank you.
Thank you very much. Okay, we have the Independent Media Arts Alliance, Pacific Region, Emma Hendricks. Welcome.